To our colleagues here sitting at Bad Hofgastein and also to all those online. I'm Natasha Tsopardi-Muscat and I'm the Director for Country Health Policies and Systems at the WHO Regional Office for Europe in Copenhagen. A warm welcome to our session on health systems regeneration, a whole system approach to quality of care, a broad and complex field. So for those of you who were already here last year, you may remember that last year we launched a report on financial protection. And this year we are actually distributing the stickers, UHC Watch, where we shone a light on access to healthcare services. But as many countries in our region have actually broadened their service packages, it's time to really focus on quality, because what is universal health coverage if we only have access, and we have access to poor quality or unsafe healthcare? Only last week we were celebrating and commemorating Patient Safety Week. And here again, we see that as health systems are struggling with the legacy of the COVID pandemic and myriad other challenges, quality has somehow faded into the back burner. And we are here with our colleagues from the Athens Office on Quality of Care to share with you today an appetizer on our upcoming report on quality of care, covering the 53 countries across our region, as well as to hear from senior people in countries across our region about their efforts on the ground every day to work to improve quality of care. Unless we can ensure quality of care and show that our systems are delivering care that is of good quality, we will lose trust. We will lose the trust of patients, and we also lose the trust of professionals who feel that their efforts may actually be in vain. But sometimes the challenge actually lies in aligning all the stakeholder interests to really make improvement on quality of care. And at the end of the day, when we look at health outcomes across our region, these are very much a factor, of course, of preventive and upstream measures. In this room, the previous session focused on the commercial determinants of health, but are also very much the result of quality care that is being delivered. So let's kick off with a keynote session by Stefan Larsson, who is the founder and chairman of the board of the International Consortium of Health Outcomes Measurement. But also I would like, before that, to remind everyone that we want this to be an interactive session. So please log into our Slido using the code June, because we will have our colleagues here in the newsroom who will be gathering your comments, questions, and reflections. Over to you, Stefan.
Thank you for inviting me to this discussion, which I hope you will find relevant and important. This whole meeting circles around a set of themes, one of which is what some people call the crisis in healthcare, the increasing challenges we see in healthcare systems around the world and in Europe. And I'm going to argue that we have three fundamental crises in our healthcare systems. The first one is a crisis of value. Costs of healthcare is growing twice the rate of GDP growth. WHO and OECD have shown that 20 to 40% of what we spend on healthcare does not contribute to better health. We do not have enough evidence to help clinicians, doctors and nurses, to take the right decisions, to avoid unnecessary care, or to give the right treatment to the right individual. Research spending is focused on developing new products to a large extent, not to help clinicians practice healthcare in a better way. But maybe worst of all, the third crisis is a purpose crisis. We have clinical colleagues, nurses, doctors, physiotherapists who are leaving the profession, burning out, or being more and more disengaged in the system. So the question is, how do we address this vicious cycle, which is not getting better over time, but worsening over time? And I would argue that we need to fundamentally rethink how we organize and manage healthcare. The purpose of the healthcare system is to deliver better health to our patients, but we're not systematically measuring the outcomes for patients. WHO has defined healthcare quality thoughtfully in public documents, and the high-quality systems are characterized, for instance, by effective, safe, and people-centered care. But I think the fundamental and most important statement in this is that high-quality care leads to better outcomes. High-quality care, by definition, has to be a care that gives better outcomes that matters to patients. Now, the beauty of that is that malaria is the same disease in Africa, southern Italy, or wherever it appears in the world. Schizophrenia is the same disease. The outcome that patients with schizophrenia or breast cancer wish are the same across our healthcare systems. Healthcare systems are different, and people can argue it's so hard to compare one system to another, but the diseases are the same, the desirable outcomes are the same, and the therapies that work are to a large extent the same. So if we focus on patients and we focus on outcomes, we can learn across systems, and we can know whether we're doing a good job or not. So at the center of this is outcomes that matter to patients. We need to look at that by different patient groups. Comparing outcomes for a breast cancer patient and somebody who's been run over by a bus is often not meaningful. We need to look at the patient groups differently and define outcomes by patient group. And finally, we need to look at the treatments that are given. If we match the patient group with the right treatment, we will have good outcomes and lower costs. This cycle is a cycle of continuous improvement and should be the definition of precision medicine. But at the center of it is measuring outcomes. Are we improving outcomes that matter to patients or not? Let me share with you two examples of where measurement of outcomes is leading to dramatic improvements. This is an outcome, an undesirable outcome for cataract surgery. It's an eye infection that rarely happens, but it happens sufficiently often in some nations, as you see. Ireland, there's example, Medicare in the United States, relatively high incidence of this eye infection. Three observations that are relevant here. The green line at the bottom is the incidence of these eye infections in Sweden. Swedish eye doctors have, over decades, measured and shared data on the incidence of these eye infections and have, during the course of 10 years, reduced the risk of infection by 90%. The best eye clinic in the United States, you could argue that, but it's argued by many to be, is Bascom Palmer. Bascom Palmer, as an institution, has the same incidence as Sweden as a nation has, and they also measure the outcomes. But as interesting is Arvind Eye Clinic in India. They have better outcomes for cataract surgery than most other nations that are enormously much more wealthy and spend more on healthcare, because they measure outcomes. Their clinicians compare the results. They learn from the outcomes that matter to these patients. So it's not a matter of money. It's a matter of operating the institution the right way, learning from the data that matters to patients. A second example is from Sweden, myocardial infarction or heart attacks, where there was a study done over several years monitoring the degree to which the 69 hospitals in the country follow the guidelines. The line in the top is the average compliance to the European guidelines across the 69 institutions. The bottom line, the 35 institutions with the highest myocardial infarction mortality. The sad thing is, the ones with the worst outcomes were improving their compliance slower than the average. But in 2007, the outcomes became transparent. The data was published. Everybody could see the mortality by hospital in the country. And the consequence was this. The compliance to guidelines at the average hospital improved dramatically. But most importantly, the hospitals with high mortality from myocardial infarction improved much faster. They realized and were embarrassed by their outcomes, so they decided to change their clinical behaviors. Transparency on outcomes changes clinical behavior, drives improvement of healthcare systems. There's evidence around the world from many institutions, and it's growing rapidly, that measuring outcomes, making the data transparent, drives change in clinical care. There's enormous academic work having been done, an exponential increase in the number of publications showing and demonstrating this. But let me share with you some of the effects of outcomes measurement and outcomes measurement transparency. You get superior outcomes for your patients, as I showed in some of the previous slides. You often get lower costs for your care because you stop doing things that do not improve outcomes. You get an improved culture in the organizations. Surgeons don't fight with anesthesiologists or fight with medics. They're in the same boat if they're measured on outcomes that matter to the patients, where they have to collaborate. You get a culture of continuous improvement that inspires clinicians instead of making them frustrated with the pressure to do volume instead of quality. You strengthen clinical research. You have access to outcomes data will allow you to do new kinds of clinical research, translational research, etc. And you get actually new levels of public-private partnerships when you align the interest of the industry with interest of patients, clinicians, and payers. You get innovation, you get collaboration at new levels. And we will find role models internationally, such as the Arvind Eye Clinic in India, that have taken this to heart and deliver superior care to their patients. There are standards having been developed already. So if you say, well, what should I measure? A not-for-profit that I co-founded 12 years ago has developed international standards for what to measure for 46 medical conditions, 60% of the global burden of disease, 1,200 leading clinicians and patients from more than 60 nations have joined forces to define these metrics, and they are published in peer-reviewed journals and publicly available for anybody who wants to use them. Finally, many of you are involved in healthcare policy, healthcare reform, to address the challenges and crises we have in healthcare. My conviction is that the central element of any healthcare system needs to be, are we delivering good health to our patients? And are we measuring it the right way? Now, how do you make that central paradigm of the system become rational behavior for all the stakeholders? One is, as policymakers, you need to make sure that it's easy to collaborate along the care chain. Primary care should not compete with secondary or tertiary care. They should be in the same boat. It should be motivating for a university hospital doctor to help primary care take care of diabetic patients. We need to have payment models that don't promote delivering volume, doing as much as possible, but doing the right thing for patients. Outcomes need to be connected to payments. Incentives need to incentivize collaboration. We need to make sure that we have access to the data so the curious clinician, nurse or others can look at the data and learn from the data how to improve the outcomes for their patients. And so strategy, reform strategy, healthcare strategy on a national, regional level, it's not enough to change the payment model. You need to have a coherent strategy which focuses on the measurement of outcomes, ensuring collaboration along the care chain, payment models that incentivize the right behaviors, and access to the data that allows research and innovation in this space. So I'll stop there with an advertisement. In 3 weeks' time, about 800 people from more than 40 nations will meet to share their experience of measuring outcomes and improving healthcare systems. I hope some of you will come and join us there. And then I have a book I wrote a year and a half ago, which, if you want to know more about this, could be helpful. Thank you.
Thank you so much, Stefan. Please take a seat on the stage. And I mean, there's just so much to unpack over there, but I heard transparency, I heard collaboration, and actually I heard what has become the tagline and the vision for our new health systems framework going to the regional committee in 4 weeks' time: the right care for the right person at the right place at the right time, delivered by the right professional. And you started to tell us actually how we can make these things happen. But now it's my pleasure to welcome to the stage my colleagues, Dr. João Breda, who heads the Athens Quality of Care Office in Greece, and his collaborators, Walter Fonseca and Lisbeth Borgermans. And together, João, Walter, and Lisbeth will give you here in Gastein a sneak preview of the report that will be published in a couple of months' time. So I hand over to you, João.
Good afternoon, everyone. Thank you, Natasha, for the kind introduction, and thank you, Stephen, for the very interesting presentation. I think I'll be the first one just to introduce to you the snapshot we would like to give you in terms of the data that we are going to present and unpack a little bit here today. In fact, there is clearly a reason for us to focus more on quality. And for a long time, we've been talking about quality, but probably not doing as much as needs to be done. But today, more than ever, we realize that with all the comorbidities, the aging of the population, the growing costs, which increase at a rate which is difficult to match by any state and other budgets, the workforce crisis that Stephen so nicely illustrated, and doctors and nurses and others, they expect different things, they have different motivations. In fact, emergent threats, obviously we live in a European region where we have wars and emergencies and of different types, and this is something that really is of importance to consider. And really the expectations that people have about the health system, people, our European citizens, are more and more demanding, and very well so. We did a couple of studies in 2 countries in the region in the European Union, and we realized that in more than 50% of these citizens, they believe that when politicians make changes in their health system, they are not taking into consideration with their opinions. So there are many things that eventually we really need to consider, and we are convinced that quality is really part of the ammunition, it's really part of the process of change, and needs to be more central. What we will see us saying today is very much about really using quality and moving from a facility approach to a more systems approach, and really putting quality at the center, which we've been describing. We talked about it. It's included in the Sustainable Development Goals. It's, of course, part of the UHC documents and policies. And as Stephen very well also illustrated, the word is there, but we need to do more. And to do more, we also need to document, and we need to have more evidence. I'm convinced, and we are delighted that with the data that we are presenting here today, the first primer for the WHO European region, I believe that we have here an opportunity and a call really to do more. We don't have many years towards the end of the Sustainable Development Goals implementation, but there is clearly an opportunity to acceleration, and putting quality at the center, we believe, should be part of the next steps. We, with our small contribution, of course, under the leadership of our regional director, Dr. Hans Kluge, and motivated, inspired by the European Program of Work, which, of course, member states will be working on the future new one, where we believe and we hope that quality will play a more central role from Greece and for Europe, serving all the 53 member states of the European region. We provide collaboration and support in these 4 areas that you see here. Country technical support, we have collaboration with more than 20 countries on a relatively intensive way at the moment as we speak. We're also very much focused on innovation and knowledge sharing, policy analysis, and network building. And this is also part of what we are doing, what we see here today, where we really trying to work together with many of you that have influential roles in the European region and in the European countries. So what you're going to see next, when Lisbeth and Wouter will be presenting the results, and they will be presenting a proposal in terms of the way forward, is really a summary of the first ever cross-sectional analysis of the current status of quality of care and patient safety in the WHO European region. This has not been done before, at least in putting together the data as we are doing it here, and will be made public with more detail later on in December when we launch the full report at the Meeting of the Minds, I hope, in Athens, in Greece. And it's also based on a survey conducted with all the member states, and which uses quality of care indicators and analysis of the micro-level data identified from international repositories. So it's not all brand new data, but it's a different way of looking and putting the data together. And finally, a call for action to prioritize healthcare quality as a driving force for UHC. As we said before, more central role in terms of UHC and the transformation process that we want to promote in terms of the health systems across the WHO European region. So I would stop here, and if you allow me, Natasha, maybe, if you allow me, I would invite Lisbeth now to give you more detail in terms of the results of this initiative. Over to you.
Thank you very much, João. It is a pleasure for me to present to you a snapshot of results of 46 indicators that we analyzed on quality of care in the WHO European region. So let us have a look together at some of the key results. Our data show that 1/3 of countries have implemented a national quality of care plan and/or patient safety plan. We were a bit surprised to see this result, as these action plans in countries who have implemented them contain provisions for systematic and aligned activities for quality planning, control, assurance, and improvement. A second result relates to the implementation of a hospital accreditation system. As you can see, 34% of countries did implement such system. We know from country experiences that hospital accreditation has the potential to drive continuous quality improvement in healthcare institutions. But evidence on the cost effectiveness and opportunity cost of these programs remain scarce. It seems, yeah. Sorry for this. A more positive result relates to the implementation of antimicrobial resistance plans. 79% of countries have such plans, but at the same time, we know that persistent disparities in AMR prevalence remain for important pathogens such as E. coli. showing also important ranges across the region. Patient and public representation in national health governance is nearly non-existent, with only 13% of countries using these policy mechanisms. And the policy instrument that is the least implemented in countries is a health misinformation prevention plan. Only 4 countries reported to have implemented such plan, while these plans have the opportunity to effectively deal with what is called infodemics during emergencies and disease outbreaks. Overall, what we noted is that the higher use of national plans and policy instruments for quality and patient safety are associated with improved health outcomes. And using a linear regression model, we have seen that for every unit increase in a policy instrument or a national action plan, healthy life expectancy at birth increases by 0.6 years, while the probability of dying from selected NCDs, such as diabetes and COPD, decreases by 1.3%. When we look at indicators for a particular quality of care dimensions, we have seen that effectiveness and efficiency indicators highlight important disease burden from NCDs and the need for the accelerated uptake of cost-effective quality improvement interventions. And I'll just give you an example. The median standardized preventable mortality rate was 164 in the region, showing a wide range from 110 to 460 per 100,000 persons. Another example relates to the 30-day mortality rate after hospital admission for acute myocardial infarction, which was 8 per 100 admissions. Looking at patient safety indicators, there we noted that overall there is poor performance when it comes to these indicators, with a high number of patient-reported medical mistakes. 5.2% of the population reported to have experienced a medical mistake when healthcare services were received, also showing wide variation across the region. While almost 85% of people reported their doctor involved them in decisions about their care, less than 1/3 of countries actually report on people-centeredness indicators, which is very low. And when we look at data on access and equity outcomes, these show high levels of unmet need in the region for health and dental care. For example, 2.2% of the population report unmet needs for dental care, again showing wide ranges in the region. When we look at the use of indicators and comparing different sub-regions, there we can see that overall, Western European countries in general report on a higher number of indicators compared to Eastern and Central Asian countries. For example, when you look at the people-centeredness indicators, the CIS countries, the Commonwealth of Independent States, none of them reported on people-centeredness indicators, but European countries showing here much better results. And we think that these regional disparities are in part explained by the income level of the countries, the political priority that is given to quality of care and patient safety, and as well as health system efficiency. And last but not least, The information on the 46 indicators that we analyzed will be brought together in what is called country profiles that we developed for each of the 53 member states in the region. And although these country profiles will not provide an unambiguous judgment on performance or quality in a country, they serve as a dashboard for countries and offer insights in outcomes for different quality of care dimensions, health system functions, and population health outcomes. And so we will soon provide the member states with these country profiles, and we hope to initiate an important and hopefully a lively debate with them on the outcomes as well as on the way forward and how we consider this way forward should look like. Well, here Walter will explain to you the recommendations that we would like to make. Thank you very much.
Thank you, Lisbeth, for this comprehensive analysis. So the question now is, how can we move forward? And I would like to call your attention to three words. First, together. Second, systems. And third, people. The first message is we need to move forward together, because if we are doing this alone, we will not achieve what we are aiming for. The second thing is we need to look to quality of care as a system approach at the system level. What does this mean? This means that usually quality is perceived or worked at the point of care level, so where professionals are providing care to patients. But sometimes these measures are not sustainable and they do not lead to effective transformations. So we need to have all the system promoting an environment where quality of care can be actually improved. And when we look for these guiding principles, we see that a whole system quality approach is critical. And one of the main tools is, of course, the national policies and strategies for quality of care and patient safety. And this deals with the right financing models. This deals with looking for a set of indicators that actually address what matters to people more on the outcome side rather than the process side. And this whole system approach will probably lead to big transformations and the ones we need to face the challenges we are facing. And the third word I was sharing with you was about people. So meaning by people, professionals and patients, families and communities. So we need to work together with them in a partnership model. So we move forward in evidence-based support for professionals, but also in engaging patients in the care design. So we are sure that we are moving in the right direction, addressing what really matters to people and their actual needs. Thank you very much.
Thank you very much, João, Lisbeth, and Walter. And it's time now, actually, to come to our newsroom. Vinny, can you tell us what's been coming in? What are people's reflections? Anything surprising? Anything that was not expected? Any questions for our panelists?
Yeah. So we've received quite a few questions. I've selected a couple. One of them is, I guess, regarding data collection. So how do you deal with doctors and specialists doctoring their medical outcomes to give falsely more positive picture?
Okay, so I think, Stefan, you have had a lot of experience over here. How do we deal with the doctors and the specialists? How do we make them part of the movement towards having the positive outcomes? Because let's face it, we know that sometimes there is resistance from also the medical professionals.
So I'm a medical doctor myself. I went to medical school because, I went to medical school because I wanted to combine my interest in science with an interest in helping people who suffer. And I think most clinicians, whether you're a nurse, doctor, or physiotherapist, you go into that profession with a passion to help. But the system has been micromanaging and forcing doctors and nurses to report on a lot of stuff that doesn't really bring better health to patients. So when you say we're going to measure outcomes, they say, well, you force us to measure so many things, don't overload us with bureaucracy and more administration. But if you say to them, we'll eliminate 90% of the stuff you measure today because we don't look at the numbers anyway, we want you to measure outcomes, and we will help you improve outcomes through access to data, through better payment models that will align your purpose as a professional with what we will praise as governments, payers, and others, you will see a workforce that is much more engaged and much more motivated than we see today. So specialist or non-specialist, nurse or physiotherapist, this is a way to get our workforce motivated and aligned with what patients want.
Very good. So clearly a message here to reframe and to focus on measuring what is important, because we overwhelm people with far too many indicators. Can we have perhaps a couple questions more? I realize that we are very tight for time, but if you can pick a couple more and we can see if we can ask our panelists to respond.
Yeah, so we have a question about the fact sheet that was presented and how these indicators, they differ from indicators that are presented by others. So how is this fact sheet different?
Okay, so I think here, João, perhaps you put a plug for our afternoon event where we will talk about the fact sheet.
Yes, so in the afternoon there's a networking session where we will distribute the fact sheet. You can have access, and we will talk about the indicators, how they were collected. It's really a novel way to put them together. Some of the indicators are collected for the first time because we reach out to member states via the WHO channels and using a survey and all of that. Others is more like a compilation of existing data in repositories that belong to the OECD or WHO or both and others. So it's really a combination of methods here. And it's really the first time it's put together like that. I think that's where the novelty is. And in a way, it's very innovative. We also have a spider diagram where we compare countries to the average of the WHO European region.
Okay, so don't give it all away, João. Come and hear more about the fact sheet at 3:45 during the coffee break. Do we have time perhaps for one last question, Vinny?
Yes, also related to the fact sheet, what strategies does the fact sheet propose to tackle disparities in quality of care, particularly in marginalized, vulnerable groups?
Okay, so we all know that marginalized and vulnerable groups suffer the most whenever quality of care suffers. So I don't know, perhaps Walter or Lisbeth, who would like to give a flavor of what the forthcoming report is recommending from the equity perspective?
Yes. So indeed, equity-oriented policies really are critical for the report, and we have tried to provide a number of examples that not only relate to income levels, how can you, let's say, target people from different income levels, but also that relate to gender, because this is also an important aspect of equity. So what we've tried in the report is really to cover different strategies that are, let's say, that result under the denominator of equity-oriented policies in the report. And we would be happy to, let's say, elaborate on this further this afternoon, because it would lead me too far to really provide you with a long list of examples, if that's okay.
Thank you, Lisbeth, and thank you also for shining a light on gender. One more, the last one, perhaps for Walter.
Yeah, so how does this new whole system approach plan to address health workforce challenges such as shortages, burnout, and which can obviously impact quality of care?
Please, a couple of words on the link between health workforce quality, burnout.
Thank you. Thank you for the question. I think it's a very interesting link. I would say it's very straightforward that it's almost impossible to aim for quality without well-trained and well-being workforce. So it's a critical component of the high-quality care that is provided. And the second and last thought actually is probably the way we can move forward is not only look for undergrad and postgrad training on these topics as well, but also to consider workforce indicators in the overall mapping of quality of care landscape at the national level.
Thank you. So please join me giving a round of applause to our panelists, Stefan, Lisbeth, Walter, and João. And we now move to the second part of our session today, where we will hear from the countries themselves. And it gives me great pleasure to introduce and welcome to the stage for our panel discussion Dr. Ana Pavo, who is the Secretary of State in the Ministry of Health of Portugal, a medical doctor by profession. Welcome. Thank you for joining us, Ana. Ms. Lilian Vildiridi, who is the Secretary General for Health Services at the Hellenic Ministry of Health. Thank you very much for being here. And Ms. Vita Steiner from Latvia, who is an advisor to the Minister of Health in Latvia. So, ladies, thank you very much for joining us for this panel discussion. I think the first part of the session has already really paved the way very nicely for what we would like to talk about. We've heard about the importance of stakeholders, we've touched upon data and indicators. So maybe I will start, Lilian, with you. We are doing a lot of work with the Ministry of Health in Greece, who has actually supported the setting up of the Quality of Care Office in Athens, because they have taken a decision that they want to really change the whole system when it comes to quality and to put quality at the heart. And as part of this big project, we are working together on an indicator framework. And of course, we know that the introduction of an indicator framework for the national strategy on quality of care and patient safety is often a subject of much discussion within countries. So what I would like to ask you, Lilian, is how you are engaging stakeholders. You're paying a lot of time and attention to this. And how do you see this as critical to the success of the strategy?
Thank you very much. It's truly a pleasure being here with you today. So truly, the essence is that by working together, by engaging all who truly play a key role in health systems, from hospital managers to caregivers to patients to policymakers, it's the only way we can actually do better in order to serve the main goal, which is provide to patients the right care at the right time by the right team. So, as you mentioned, with the WHO office in Athens, what I mentioned was the foundations of how we worked during the past months, because for the first time in Greece, we're actually developing a national strategy on quality assurance, patient safety, and patient engagement. So we worked with everyone, with the 7 health regional authorities, under which the 127 hospitals in the country lie under, because the whole concept is from a, if you want, government perspective. In order to apply any change, it doesn't only matter to describe it and set the foundations, it's to actually transfuse the core of the essence to the people that are going to operate on a daily basis. So caregivers and hospital staff had to understand the value of it in order to implement it on a daily basis. Patients have to understand the value it will pose on the service provision they will get. So altogether, actually drive change.
Thank you, and thank you really for also highlighting that accent on patients. We just saw from the presentation, and I think I asked a couple of times, no, when I saw the data, are you sure? Are you certain? 13% of countries only have institutionalized, in a formal way, having the patient's voice in the decision-making. And we know how important this is for trust, for transparency, for accountability. One of the countries that is leading the pack in this area is actually Latvia. So perhaps, Vita, you can tell us about how you have institutionalized patient and public representation, and maybe you can share with us also how politicians were persuaded to make this a key pillar.
Well, thank you. Great question. First of all, I'd like to highlight there are like two-level cooperation in Latvia. First is on facility level, and then there is a national level. Speaking about facility level, these are patient advisory boards. At the moment, we have very active one for Children's University Hospital. They are, I would say, involved in a minor issue solving on a hospital level, and also they are contributing to the changes in legislation as well. So they are acting on national level as well. In next year, we are going to develop 2 new patient boards, patient advisory boards in 2 largest adult hospitals as well. I think this is working quite well, and it is based on international experience. Then there is a national level. On national level, we have 2 formal partners where patient organizations are included. One is strategic board. A strategic board consists of public and private stakeholders and patient organizations as well. They meet with the representatives of health ministry and related institutions quarterly, and they address issues that needs to be solved in healthcare system. And then there is a formal partner that is patient organization network that is consisting of 30 different patient organizations. And there is a bit of issue because of the quite frequent political changes that sometimes happen once per year. There is no continuity, and the trust from the patient organizations decrease because all the agreements, well, they lose their
validity.
Yes, validity. And they have to start all over again. And that's why we need to work on sustainability, on continuity in cooperation with the patient organizations.
Thank you very much for really sharing very honestly this account of what you have actually put in place and where also it still needs some fine-tuning. Okay, so we've spoken about patients, and now we must come, of course, to the health professionals. I think this was also mentioned earlier. But let me start, Anna, by actually saying, you know, when looking from a distance, looking at the data, we see that Portugal has made great strides, and there are some indicators where it does really well, particularly, for example, on preventing hospital admissions for conditions such as congestive heart failure, asthma, that can be treated in primary health care. Stefan made a very good link between the hospitals and the primary health care. And I know that you have invested a lot of time and energy in developing clinical guidelines that are going across the whole of the health system rather than just being at facility level. But how do you bring the health professionals on board to own, to champion, to adhere to these clinical guidelines?
Hello, thank you. That's a very good question. It's true that Portugal have already some years clinical practice guidelines that are under the direction of the Director General of Health. Right now, what we need to stop and think, it's important not only to promote it, but to engage the professional health with it. Right now, we are going to take place a reform in the public health system in Portugal. In Portugal, we have already done some reforms in the primary care, in the hospital system, but we never promote a public health reform. One of our focus is to create policies that promotion the health and prevention, because it's one of the ways to contribute to sustainably the health system. And of course, to do this, we need to understand our epidemiology of the disease and to create policies that understand it. One way is to develop the clinical practice guidelines. That's something we want to do. We want to reform it and to create and develop really clinical guidelines to answer to really programs and problems. And we also want to connect these clinical guidelines with our national pharmacy guidelines. And doing this, we also are going to promote the sustainability of the system. And one of the ways to engage the professional with it. Portugal is an example of digital health. We have digital health systems lots of years ago. We are now developing a data lake. And I think that's make possible to build algorithm of the decisions. If we don't only give clinical guidelines to our professionals, but always also give digital decisions opportunity, I think that's the better way to engage them. In some hospitals, they already have some algorithm of decision that help the professionals. And I think that's the better way to work with the professionals.
Thank you, Anna. I mean, so much to unpack in that intervention, but let's just take 10 seconds also. You mentioned pharmacy, and today is World Pharmacists Day. A year ago here, we were talking about health workforce, and we were challenged of overlooking the pharmacies and the pharmacists. And actually, yesterday, we launched a commentary together with the Federation of International Pharmacists about the roles of pharmacies. And the discussion at the symposium in Copenhagen was really about bringing the work on the quality of the products with the actual service delivery. So thank you for touching upon this need to bring the kind of quality use on the products within the systemic approach. And you've opened, of course, now the channel on digital. And I think this is an area that we really need to take into account very, very critically. It's a new dimension. If we were struggling with quality of health service provision in the analog world, we now have the digital world that provides tremendous opportunities, as you have just said, Anna, but of course also provides certain threats if we don't have in place systems that can ensure the quality of the digital technologies that we are using in our systems. And this, I think, is one of the next big frontiers that we need to tackle all together. For a country like Greece, with all the beautiful islands, we know that digital holds a lot of promise, also to try and bridge some of the equity gaps. And we know that during the COVID pandemic, for example, telepsychiatry took off very well in Greece. But can you tell us a little bit, Lillian, about how you are paying attention also to the rollout of digital and engaging the professionals with that?
I'll briefly make a small introduction just to underline about the importance of that. And mainly to clear a misconception that is usually being made. The economic sustainability of health systems and quality assurance, they're actually not mutually exclusive, but on the contrary, mutually inclusive and should be seen like that. Because evidence-based policy is the only way to allocate specific resources. If we look at it each government, each country, has a specific budget allocated to healthcare and increasing challenges. For example, aging population, new diseases, increasing costs of new medicine and innovative drugs. Hence, you have to make the most out of your allocated resources. And the only way to do that is if you put outputs in each policy and you overlook them in each policy you put forward. This whole discussion about the good use of resources gets even more perplexed when geographical imbalances come if you want to ensure equity and access throughout a country. And here is where digital tools come in. In Greece, we do allocate 300 million on the digital transformation of healthcare through funding from Next Generation EU. And by the end of 2025, we will have the telemedicine instituted in all hospitals and health centers around the country. And of course, with the help of WHO, Athens office, we will put the processes which are necessary and the procedures and the performance metrics which are necessary to overlook that. But on that point, when geographical imbalances come in, but not only, a very important thing is to see how you allocate the workforce in order to ensure quality of services. Because of course, it's understandable that you can't have a doctor of each specialty in every island, because to ensure quality, a professional health, for example, a surgeon has to operate a specific number of surgeries a year in order to be fit and to adhere to the quality standards. Hence, I would like also, since we're talking about digital tools, to touch upon a great project we're doing with WHO under the IQ program, which is a platform, an information system on the workforce, on their resources we have in healthcare, which will have aggregated set of all the workforce in every hospital in the country, in order to manage, in the end of the day, to match the need for health services provision with the supply. And this will be extremely important because what it will add is prediction models. So every year, we will know with literally the touch of a button what new job openings we have to offer, what movements we have to dictate of health personnel depending on the need, to adjust, if you want, during summer months and the increase in tourism. So a big thank you for that, and we're really looking forward to utilizing this tool for better resource allocation in Greece.
Thank you, Lillian, and good luck with all the reforms that you are really pursuing in Greece at the moment. And you mentioned the predictability, the use of indicators. So perhaps if I come back to you, Anna, and ask you, how are you using the data, the indicators, to actually drive organizational changes and improvements, also building on what Lillian has just been describing?
Thank you. As we see today, measure results in health. It's very important. And it's also very important that I read something that was talking yesterday here, is how the health minister explained to the other ministers of the government the need for the increasing budget in health. So we need to show results. We need to add value. It's the only way to justify our budget. So what we have in Portugal regarding clinical indicators. I will speak about two different things. One in the primary health care, and the other that we have and we haven't anymore in the hospitals. Regarding to the primary health care, we developed one financial model that we call the B model, when we pay regarding results. So we create different indicators based on not only the results, but the way the professionals pay to the patient. For example, how they follow up the diabetic patients, how they follow up the hypertension patients, how they follow the kids and the women. And if they do everything, we pay more. This is an important thing to change the results in the health system in Portugal. We want to change right now all the clinical on the primary care to this kind of model. And we present some weeks ago the model CIS, where we are open the same model to the social and private care. For the hospital care, we developed in 2008 a program that we call SINAS. SINAS was in the regulatory agents, and what we do is to look to the hospitals and to see the indicators regarding general vision, for example, the pathway of the patient in the hospital, the satisfaction of the patient, the infrastructure structure, and we will also measure some clinical indicators in areas that are defined. For example, cardiac surgery, ambulatory surgery, hip replacement surgery. And the best thing of this model is that it was possible to do benchmarking between the hospitals. And what we see that each year the hospitals have better results. And why? Because they competed between them. During COVID, this system, I don't know, have finished, but we now, using the reform of the public health, using the reform of the quality department in the public health, we want to bring it
back
again.
And I think this really echoes what Stefan was saying, that we know that when we have this transparency, behaviors will change. But you also mentioned an important point around showing the funders. And I think coming back to the trust, and of course with Martin McKee we worked a lot on identifying how to unpack trust and the different constituencies. We mentioned the patients, and we will come back to the patients to close. We mentioned the health professionals, but we also need to have the trust of those who are putting the money in the system. And this is the way that by measuring and showing in a very transparent way our indicators, we can close the loop also with getting the trust of those people who are putting the funding in the system. So thank you for illustrating that point. We're really nearing the very end, and my last question comes to Vita, because at the end of the day, we have a plethora of indicators that we could measure, and we don't want to overwhelm people. But definitely, we need to make sure that we are measuring the indicators that are important for patients. And I know that in Latvia, you are really working very much on patient-reported experience measures. So briefly, perhaps you can tell us a little bit what you have learned from this experience.
Yes, I'm really proud about Latvia. I think we are leaders in Europe, actually, in PREMs. So we have 3 national PREMs already, patient experience questionnaires. One is for inpatients, the other one is for obstetrics, and third one is for mental health patients. We have two data available in 2 levels. One is on national level, because all 3 questionnaires are administered by the Center of Disease Prevention and Control. So basically they collect the aggregated data, and these data shows the weaknesses and strengths of the system. On facility level, all data is related to the units, to the team performance. So if we talk about data is not actually important if there are no following steps, like improvements. So if we want to go to the improvement part, then if you really want hospitals to improve their results, you have to show data that is related to the teams, because they really are competitive and they like to know what is their input in general data. they are not very much interested in general national data because they don't see their input in there. So it's very important that we lack at the moment in Latvia is pay for quality initiatives. We have pay for services. So third step would be after improvements on national level to transit from pay for services to pay for quality.
But thank you so much for illustrating this point about the teams really seeing themselves and their performers. We have perhaps just a couple of minutes left, and I'd like to see if we have any questions or reflections from the audience that we can take in. Anybody has? There's a question here, and there's another one at the back.
Hello.
Introduce yourself, please.
My name is Maria Loureiro. I work for the European Commission, for DG HERA. Very simple question. Do you think that medical coding, so the promotion of coding of electronic health records, holds an important place in tracking these standards, these metrics that we are talking about?
Stefan, do you want me to throw this one to you, please, until we take the microphone to the next person?
If the electronic medical records captures outcomes that matter to patients, I agree with you, but typically they don't. And the big software companies today, that Epic, Cerner, and many others, they don't really have included outcomes that matter to patients. So you can look at a lot of things, but the essence is to understand, are we succeeding or not? So I think we should put pressure on those organizations to make sure that that's included. So as a clinician, you can get access to the data. But just one more comment. The data in itself is not helpful unless you have the underlying statistics. When I see the prompt for my patient, I need to know, for this category of patient, is this good or bad? And so just the data will overwhelm you, but if you have the statistics, you will know that there's something I'm doing right or something I'm doing wrong. So we need to combine the data with the statistics to make it useful.
Data, statistics, information. João wanted to
Just
make
to
a quick
add
comment,
exactly
and then we'll take the question down
what we are doing in Greece now. We're using the electronic data records integrated with all the information sources and putting together in terms of the quality platform we're developing that Greece is doing it.
There's a question down there. Please introduce yourself.
Hi, guys. Mark Hennessy, Department of Health, Ireland. Thanks very much for the great session, firstly. And this is also something we're kind of thinking about conceptually. One thing that we're kind of struggling with, though, is there's seemingly a gap in the data available for certain objectives or certain kind of areas of performance that we'd like to improve in hospitals relative to what's currently available. And oftentimes making the case for data systems investment that will actually facilitate this kind of targeted intervention, driven by key performance indicators, is difficult because there's a large disconnect, or there's a long path to go between an initial investment in a data system and a final outcome in terms of patient improvement. So I'm just wondering what thoughts you have in terms of how to motivate, politicians or kind of the system to reflect on data systems improvement as a measure to ultimately lead to patient improvement. Thanks.
Lillian, can I hand this one to you?
You're completely right. Having the right source of information is key in order to implement any change which will be outcome-based. In the Greek case, you're also right that we weren't a country which had the necessary information or the data set. However, we were lucky enough, as I mentioned, to have the funds either through RRF, through the support of WHO, to design from scratch the information systems that we will need. It took us almost 2 years in order to design the digital infrastructure that we will need to actually end up having the outcomes incorporated in the medical file, in every policy that we're putting forward, for example, home care, workforce allocation. So I think it's something that should be done from scratch. Have the design, have the outcomes, and truly incorporate the end goal and the outcomes and the KPIs you want to measure from the initial design. Only then you will be able to have credible data and credible outcome to take the next stage, which could be pay for performance to professionals or targeted financial incentives and all this sort of things.
Thank you, Lillian, because I think these are the conversations that show that we're going from the theory to the practice. We're standing between an interesting discussion and some lunch, but I think we can take a couple of questions more.
Yes, thank you very much. Nick Guldeman from the Netherlands. I'm fully convinced about the use of information indicators to improve care, although I'm a little bit concerned based on observation in the Netherlands. So we have a very dominated discussion on this already for 15 years, mainly academic, and we have some nice projects and research done on this process. The current situation is we are overwhelmed with these sort of indicators and quality from authorities, from health insurers. But if you look to the workforce, the frontline workers, they are not supporting anymore, or they don't have the resources to improve the process. And the prospect is also that it won't be any better in the near future. So the concern is that we are focusing, like the last 15 years, so much focus on these indicators and quality outcomes rather than really support our workforce to make this improvement happen. So how would you see this in the current challenges?
Anna will take that question. I will then go to the lady in red, and then to Martin, and then close.
So I think is when we talk about doing the clinical guidelines, we also need to do clinical procedure guidelines that effectively help the health professionals to apply in the practice. I think the problem is to give them solutions and not more work. They need to be engaged in the development of this clinical practice. I think that's the way to build something. I totally agree with you. We have lots of clinical indicators. We have lots of results. Now it's time to take this and put it in the practice.
Nick, I can see that Lillian is burning to say something.
In practice, something that worked for us, and I think Joao can confirm, when we try to instill WHO guidelines on patient safety and quality assurance, we first sent a self-questionnaire to hospitals. They completed it by themselves in 2 weeks, and then the groups from WHO and from our quality assurance agency actually went on site to give directions, recommendations, and for us, this worked very well, and I think is a case and a best practice which can be followed by other countries.
Thank you.
The lady in red. I'm Elena Mora, I'm professor of neurology and director of the Department of Psychiatry and Neurology in Grenoble Hospital in France. I want to ask you a question connecting to what he said. There is a shortage of physicians in Europe. And what I understood that you asked the hospital to increase the number of consultation. So how do we can manage this, even because the patients are more complex? They have several comorbidities, so it takes more time to assess them. So how can you manage what he said, all the complexity of the system with the shortage of physicians in Europe?
I don't know. Is this referring to something that Anna said?
We don't say we need to. Of course, we need to answer to the population. We need to give him access to the health care. That's something, when you need to solve any problems, that's something. You can't do any reform if you don't give first access to patients. What we need is to organize the service. What you need is to have better primary care and to refer to the hospitals only the patients we need. I don't know if I answer to your question.
It's, of course, a very critical issue, and I would like to second that with all the countries that we are working with, workforce at the moment is the top issue of concern. But But we spoke about that last year, and of course, we need to make the link. We can't talk about quality without talking about workforce and patients, which is what I think we've tried to do. Last words from Martin before I hand over to João to close.
Yeah, so we've talked a lot about the performance of providers, but how the results that they get are a function of how well they do their job and the condition of the patients that are coming into them. And unless you've got record linkage and linkage to census data and all sorts of other things, you know, we know that hospital death rates, for example, are a function of the hospital and the catchment area that it's working in. And if you don't have those data, and if you don't have data on ethnicity, you know, we pretend in Europe that everybody gets treated the same regardless of the color of their skin. They don't. I just wonder, are you not in danger of actually penalising providers who are working very hard in disadvantaged circumstances where they're struggling to attract and retain staff, and you tell them that they're not doing well, and they say, we're doing everything we can in the circumstances, because they're picking up the pieces of failures in other areas of government policy. And the danger of these things is that people do manipulate the data because it's so easy to do that. And you can create a vicious downward spiral. So I would just urge a little bit of caution, speaking as somebody who wrote about this originally in, I think, 1990.
Absolutely, Martin, and I think this is why we are trying to go from the facility level to the systemic level, and just also really placing health systems within the broader economic and societal frameworks. We're over time, so I will just hand over to João to say the thank yous to everyone now.
Thank you. Thank you, everyone, particularly to Natasha for so beautifully ending and managing the session. I think we go home very reassured that this is really an important topic and that we should pursue and continue our work. We had great speakers, great questions, an excellent discussion. I think that it shows in a way that our path is going in the right direction. There's innovation in this field. I think that the work it's being done in Greece, particularly in this area of quality and putting indicators together, the work we are doing, for example, also with colleagues in Romania, where we're coming up with a very small set of indicators that can help them look at the system in general and also provide feedback into their financial issues. I fully agree with what you said, Martin. It's very important, but this data is going to be also part of the work we are doing in Greece. We're looking at the catching area and all of that, because it's really critical that we take into account the failures of education, health promotion, and all the commercial determinants. Thank you very much for the panel. You are really fantastic, and I think this is really food for thought. And more on this in the future, and don't forget to watch the launch of the report in December, probably December 11. Thank you very much. Meeting adjourned.